So a good place to start this video is to acknowledge that panic attacks are horrible and they suck. They are these episodes of discrete, intense fear and panic as if you're gonna die. The fight or flight response gets activated, your heart might beat, you sweat, you shake, you might feel really like you're going to die. And it's completely debilitating. You can't continue shopping, you can't finish your essay, you can't do anything else if you're in a panic attack. They are horrible. And a lot of people will experience a panic attack, and some people may even go on to develop panic disorder. And that's what this video is all about. So in this video, we're going to be talking about panic disorder. Essentially, when panic attacks become so common for so long that they affect your function and your ability to live the life you want. We're going to be talking about the epidemiology, how common the disorder is, comorbidities, the other illnesses, the mental illnesses that panic disorder is associated with. We're going to talk about the cause and the thinking and science around why some people get panic disorder and some people don't. All the different symptoms one can experience and essentially what you should tell your doctor if you're going for an assessment. We'll run through the diagnostic criteria, but also make sure to just address that there's a lot of other conditions that can have similar symptoms and talk about some of those other conditions. And finally, we'll also go through the treatments for panic disorder. So if that sounds like your cup of tea, let's get into it. Now, the first thing to say that's extremely important is that you cannot diagnose yourself based off of a YouTube video. You need to go see your doctor and get a personalized diagnosis. I'm making these videos to better educate and empower you to ask more specific questions because you have better insight into mental illness watching these things. So I cannot diagnose you through this YouTube interface, but I can help teach you some important things to know, to discuss when you do meet with your doctor for that diagnosis. I should just introduce myself though. Hello, I'm Dr. Sil. I'm a junior doctor working in mental health in Sydney, Australia. I start in the training program soon, and I love making YouTube videos about mental health medicine, when I do have some free time, that is. I've got heaps of other content related to mental health reactions and life as a doctor, so if you're interested in that kind of stuff, please consider subscribing to the channel. So let's get started talking about panic disorder. Let's first off start off with a definition that we agree upon. Patients with panic disorder experience recurrent, untriggered panic attacks with 1 month or more of worry about future attacks and or maladaptive changes in behaviors related to the attacks. That means they might stop going to work because they're worried they'll get a panic attack. That means they might break up with a partner because they're worried about getting a panic attack with the partner. They'll change their behavior in a way that is considered maladaptive, not healthy. It affects their function in life. So that is what we're talking about. And now let's begin with how common it is, the epidemiology. So how common is it? Well, according to this study from the US, there is an almost 5% lifetime prevalence rate of panic disorder. That means 5% of people at one point in their life will have so many panic attacks that it is considered a panic disorder. Essentially what I'm trying to say is it's very common. 5% is way more than I expected. I mean, it's technically 4.7%, but it's like basically 5%. And yes, this study was just in the US, but you can kind of expand that out to other developed societies, like Australia, like the UK. In that study, they also showed that the average age of onset is 24 years old, and that it's almost twice as more common in females as it is in men. Alright, let's talk about some of the common comorbidities, associated illnesses that you see with panic disorder. So when talking about comorbidities, it's really important to know that panic attacks can be seen with lots of different mental illness and may not be panic disorder, which is the main problem. If, for example, I'm not saying you have it or anyone has it, but I'm just saying, for example, if someone has, let's call it mania, bipolar, and they are getting panic attacks, but they also have bipolar, and the panic attacks are secondary to their manic state because they're hearing voices because they're manic and it's scaring them and it's causing panic attacks. Treating the panic disorder won't solve the problem, all right? It's really the bipolar that is the main issue there. And that's a pretty obvious example, but there's a lot of more subtle distinguishing things that need to be done by a doctor. So all this to say that you need to see a professional, preferably a psychiatrist, to distinguish and get a proper diagnosis. Or in some cases, a dual diagnosis, a panic disorder as well as something else like a bipolar disorder. But the common associated illnesses you might see with panic disorder are things like mood disorders, things like depression, things like generalized anxiety disorder, post-traumatic stress disorder, somatic symptom disorder, illness anxiety disorder, where you are overinterpreting bodily sensations and thinking that you're having very severe illnesses, though tests can't prove that. And of course, substance use disorders are very common, self-medicating through drugs and alcohol, unfortunately. And a really important one to say is agoraphobia, a fear of leaving, well, technically a fear of going into places you can't escape, usually big crowded places like the shops or whatever, but it can essentially be associated with fear of leaving the house. And that makes sense, right? If you're getting panic attacks only when you leave, and when you're at home you're not getting panic attacks, you're going to stop wanting to leave the house. And then you start panicking every time you need to leave the house. And it's pretty crazy these days, just to take a tangent, that with the way that deliveries are going, you essentially never really have to leave the house. You could work on a computer from home, get everything delivered to you, and you don't ever have to leave the house. That just boggles my mind. That's the way society's going, I guess. But anyway, that's a tangent. Agoraphobia is a common comorbidity, is the point. Now guys, those were the psychiatric comorbidities, but you can also get medical comorbidities. So asthma, cardiovascular disease with angina, these kind of things where you get short of breath from a medical trigger, it can trigger a panic attack, because obviously if you are having trouble breathing because of your asthma, you're not going to feel very good. You're going to start being quite anxious and it can lead to a panic attack. So yes, you can have medical comorbidities as well as psychiatric comorbidities. Now, what is the cause of panic disorder? What causes it? Well, as always, we'll go for the biopsychosocial approach in order to discussing the different suspected causes. And really the model that is used is the stress diathesis model, which is essentially this approach we use for a lot of things like generalized anxiety disorder, depression, bipolar, a couple of other disorders. It's a common thing where essentially you have a model that says that you have a genetic predisposition with multiple different genes that, when they're put together in you or the person suffering from this disorder, can get activated if you have an environmental stressor or stressors, multiple, such as adverse childhood events and things like that, drugs and alcohol, bad abuse, bad environmental things happen, and they activate the genes, and then you develop the disorder. That's the kind of thinking, the stress diathesis model. So for example, genetics, the evidence shows that first-degree relatives of patients with panic disorder have higher rates of panic disorder than relatives of people with major depressive or healthy controls. And so when we see these studies that show that first-degree relatives have higher rates of the illness when they're related to people who have the illness, it suggests that there's probably a genetic basis. But we know that it's not 100% because we have seen twin studies that show there was high concordance in monozygotic twins compared to dizygotic twins. So 31% for the monozygotic twins compared to 0% in the dizygotic twins. And what that suggests is that it's not 100% genetic. It's not like, an intellectual disability where you get a gene mutation that's completely a genetic cause. It's partly genetic and it's partly environmental. Because obviously if it was fully genetic, then if you had a twin study of monozygotic identical twins, if one twin had it, the other twin would have to have it as well. But we don't see that. We only see that in about 40% of cases. Now, when you're looking at the brain, when you put people with panic disorder in an MRI and you're looking at the brain areas that are hyperactive, you can see that there are certain brain areas like the amygdala and the hypothalamus. These are important brain structures in coordinating the fight and flight and freeze response that triggers the panic feeling in the brain. There's the prefrontal cortex as well, which is an important brain area in monitoring your endogenous state, and it can trigger behavioral and autonomic and endocrinological responses to stresses. And there have been some controlled studies that support these circuits being activated in panic disorder. I should just say now that, we've got to remain humble. This stuff can change. We're not 100% sure that this is how it works because you can't just take a brain out and test it. So these are just kind of association studies where we see activity in these areas in people who are having panic attacks. But there's a lot of problems in the research, and an fMRI machine it's not a very sensitive, specific instrument. You can't really make out nuanced changes in the different neurons. Now that's the kind of biological factors. Now as for the psychosocial factors, and as I said before, it's really around childhood adversity, around physical, sexual, emotional abuse at a young age. Also, smoking in childhood does increase the risk of developing panic disorder. And there's also personality factors. So having an anxious temperament or high levels of neuroticism is associated with anxiety disorders in general, and also panic disorders, which can be considered an anxiety disorder. And that kind of makes sense. Someone who's high in neuroticism might have a predisposition to catastrophizing things and assuming things could turn out for the worst, and that could definitely lead into catastrophic thinking, and therefore, if that was left unchecked, or if it was a very severe neuroticism, could lead to a panic attack. Alright, so that's a bit about the cause. Now, let's talk a little bit about what you need to report to your doctor, the things you and your doctor need to talk about. So you need to talk about what happens when you're having a panic attack and how long it lasts for. Because according to the DSM, the panic attack has an onset that is abrupt. It usually starts within minutes, and it usually resolves within an hour. So they do end. You usually get this surge of intense discomfort and worry and sometimes fear of death, like you might be dying. And to actually meet the criteria for a panic attack, you have to have 4 of these following 13 symptoms. So number 1 is palpitations, or a pounding heart, or feeling an accelerated heart rate, maybe on your smartwatch or something. Sweating is number 2. Number 3 is trembling or shaking, sensations of shortness of breath, or that your breath is being smothered. You might also have the feelings that you're choking. You might get chest pain or even discomfort, and often people get nauseous and feel like vomiting, or even get abdominal pain or distress. You can also get the feeling that you are dizzy or unsteady on your feet, feeling lightheaded. Some people get chills or really, really hot. Some people get pins and needles, numbness and tingling sensations in their hands or feet. Some people even kind of dissociate and get derealization, where they feel like the reality they're in isn't actually the real world, or that they're kind of separated from the world and just watching themselves. You can also have fear of losing control, or that you're going crazy, and often, I've seen it at least in the emergency department when I've done my emergency medicine terms, you see people with a fear of dying. They think they're going to die. And when you're in the emergency department and someone's coming in with a panic attack, you always treat it like it's a real medical emergency, okay? Because it could be. So you put the ECG on, you do the chest x-ray, you take the troponins, you look if they're complaining of chest pain or whatever, and you make sure it's not a heart attack. And then hopefully that all comes back negative and it's a panic attack, and then it's still serious, but it's not as life-threatening as a heart attack. So that's good news in a way. So that's the symptomology that you need to report to your doctor. You also have to talk about if you have any other associated kind of symptoms. So fear of leaving the house, or fear of going into group areas. If you're using any substances, drugs and alcohol, you have to tell your doctor about that. And it can be a bit hard to bring up, and your doctor should ask about it. But if they don't, you need to talk about if you have risk for suicide. So if you've previously attempted, or if you're planning to, or if you're kind of can't stop imagining suicide, you need to report that to your doctor. Another important thing to talk about is whether these panic attacks are being triggered or untriggered, because for it to be a panic disorder, you actually have to have some that are untriggered. If they're always triggered by a thing, then that's a little bit different. But for panic disorder, what we're talking about today, you have to have some that come out of the blue that are unpredictable. Make sure your doctor knows your past medical history, especially if you have asthma or heart disease. Make sure they know if you have any other psychiatric history, and make sure they're aware if you're seeing any other mental health professionals like a psychologist or a counselor or a GP. All right, I think that's a good job covering, the things you need to talk to your doctor about. If you are diagnosed with panic disorder, let's talk just briefly about the different management options for you. What can be done to treat it? I guess the important thing to say first is the course of the illness is that it is not curable. It is a chronic condition, and it usually relapses in people, but often you can have long bouts of symptom-free periods, which is really good. But some people do, get full remission lifelong and don't get more panic attacks. But, it's hard to know who's going to respond and who isn't, and I can't tell you if you're going to respond. I guess the important thing to say is most people do get benefit from treatments to a significant degree. Most people do. Now, when talking about the treatments for panic disorder, it's really a question of, do you need treatment? Essentially, is it so severe that you need to get therapy or medications because it's affecting your quality of life? If it is, then the question is medications, therapy, or both, right? And the quick off the bat, answer is you should do both, right? But if you're scared of the side effects of the medications, you can start with therapy. Or if you want, a response quicker than therapy can give, then you can go for medications. It's worth noting though that with the medications, there's a lot of different options. So, if you're scared about, sexual side effects, you can change to one that has less sexual side effects. If you're worried about weight gain, you can change to one that has lower risk of weight gain. So there's a lot of different options, and it's not because the first medicine that you try doesn't work that the next ones won't work. So even if the first one doesn't work, don't lose hope. And with psychotherapy, the same thing applies. It's not, the most important thing in therapy is your relationship with the psychologist. So you just need to find someone that you work well with. And if you've had a shit psychologist, which is common, well, it's not common, but it does happen, don't let that dishearten you. You just have to persevere and find someone that you work well with. Now, in terms of the medications, if you do start on something, it's usually going to be a selective serotonin reuptake inhibitor or a serotonin and noradrenaline reuptake inhibitor. We don't fully understand how they work, but they seem to increase the amount of serotonin in the brain, and that seems to have an effect on neuroplasticity, which is really what you want, because you've essentially got these unhealthy brain circuits firing, making you have a fight or flight response, and you need to retrain them with therapy to not trigger. And that needs neuroplasticity, which is essentially the ability for the brain to change itself. So the medications help the brain change the unhealthy pathways. But guess what? You need to do the therapy. You can't dodge therapy, guys. And you see this a lot in anxiety disorders, that people take a pill and then dodge the therapy. No. The pill is to help the therapy. That's where the hard work is. I always say it. The medication is kind of like a good pair of boots, right? It helps, but you still need to walk up the mountain. Okay, the mountain is the hard work, and that's what you have to do to get to the top of the hill. And the medicine's important in having a good pair of shoes, because you don't want to walk barefoot. But you can, some people can, so you don't have to take the medicines. But yeah, it kind of depends on an individual case-by-case basis. And that's why there are doctors that exist. If you could just diagnose yourself off of a YouTube video, you wouldn't need doctors. Now, how long do you need the treatments for? Well, if it's medicines, you usually continue them for 1 year after symptom remission. Then you can start weaning and see how you go. And if it's therapy, usually you do about 15 or so CBT sessions, cognitive behavioral therapy sessions. But some people need more or less, and some people need ongoing check-in sessions once a month or so. As I said, if there is treatment resistance and you don't work off the first or second, do not stress out. There's lots of other options. So it requires patience. Every medicine takes about 2 to 6 weeks to show effect, and the therapy can take weeks to months to have effect as well. It's a long-term kind of situation. You have to have your long-termism cap on. You won't get results straight away unless you take a benzo, but benzos you can't take long-term, and they're just short-term fixes. You need long-term results and solutions. But I'm optimistic that with watching these kind of content, being educated, being empowered, you can now go talk to your doctor with better insight, better knowledge. And if you're a GP or a healthcare professional, you can talk, or a counselor or a psychologist or whatever. You can also talk to your patients about this video and this kind of these things to talk about. So you're both better empowered and better educated, and it's good. And on that positive note, I will end it there. If you found it helpful, please leave the video a like and subscribe to the channel if you haven't yet. And join me on this wonderful journey through YouTube. I wish you all a beautiful day, and I'll see you in the next video. Bye for now.